Hello friends, welcome to my YouTube channel. In previous video I have talked about how to identify respiratory distress in a newborn, how to approach a case of respiratory distress in a newborn, and about the respiratory distress syndrome condition. And in this video we are going to continue the same topic, respiratory distress in a newborn, and with the condition neonatal pulmonary alveolar proteinosis. This is also one of the most important conditions which presents with respiratory distress in a newborn, and the basic defect here is the deficiency of surfactant protein B. So what does surfactant protein B does actually in the lungs? It forms the thin layer of surfactant in the inner layer of the alveoli, thereby preventing the alveoli from collapsing during expiration. The clinical feature of pulmonary alveolar proteinosis is initially it presents as a respiratory distress syndrome in a term neonate with no improvement on surfactant therapy. Initially, it mimics like a respiratory distress syndrome (RDS), but on surfactant therapy, it doesn't improve. No improvement on surfactant therapy suggests the patient may be suffering from pulmonary alveolar proteinosis. There will be family history of similar illness in a previous sibling who died because of the similar condition, and chest X-ray looks similar to respiratory distress syndrome. It looks ground glass opacity with no improvement on surfactant therapy should evoke the diagnosis of pulmonary alveolar proteinosis in a newborn presenting with respiratory distress. Let's move to another important condition, meconium aspiration syndrome. Let us first understand what is meconium. Meconium is nothing but first stool passed by a neonate. It is greenish black in color, and the pathophysiology involved in meconium aspiration syndrome (MAS) is this: the aspirated meconium goes and blocks the bronchi or bronchioli, causing obstructive emphysema. It's the most common and most important pathophysiology in meconium aspiration syndrome, and of course meconium causes chemical pneumonitis, and it also causes segmental collapse or atelectasis. Patient presents with respiratory distress in a term or short for gestational age IUGR baby born through meconium stained liquor or meconium stained amniotic fluid. You have to suspect meconium aspiration syndrome. On examination, the AP diameter of the chest is increased. That is because of emphysematous change. And on chest X-ray, you will see typical emphysematous changes like hyperinflated lung fields and pulmonary infiltrates and segmental collapse. This is how the X-ray looks in the case of MAS, meconium aspiration syndrome: hyperinflated lung fields, flattening of the diaphragm, widening of the intercostal spaces, and there will be some pulmonary infiltrates are seen, and segmental collapse are also seen, where the bronchus is completely closed. In that segment, the atelectasis is seen. Now let us move to the treatment of this MAS condition. So here treatment is supportive care in the form of oxygen and mechanical ventilation. Severe cases we give intratracheal surfactant, and even we can consider high frequency ventilation or ECMO. And the complications are very important in this condition because they often occur in these conditions. The complication here includes, they are very understandable. The lungs are hyperinflated. There are emphysematous changes throughout the lungs, and these emphysematous bullas may rupture and may cause pneumothorax, and because of continuous hypoxia, the pulmonary vessels are constricted, thereby causing persistent pulmonary hypertension. These are the complications that you have to remember, and they are associated with almost all respiratory distress in a newborn, and they are associated with almost all conditions which are present. They are associated with almost all conditions presenting as respiratory distress in a newborn. Let us now move to the another condition, that is transient tachypnea of newborn. This is the most common cause of respiratory distress in a term neonate. Mark my word, term neonate. Here the basic defect is delayed clearance of lung fluids. Normally the baby is born with lung fluids. In case of normal delivery, normal vaginal delivery, because of the mechanism of normal vaginal delivery, the squeezing that takes place during normal vaginal delivery will help in clearing the lung fluids. But in case of what happens in cases of cesarean section, there won't be such mechanisms happening, so the lung fluids may remain in the lungs for longer duration, and it may take a while to clear the lung fluids for the babies born through cesarean section. The risk factors for TTNB is babies born with cesarean section. The clinical features here, the term or post-term babies born by cesarean section presenting with respiratory distress, then it is a spontaneously resolving condition. It resolves within 72 hours, and you don't have to worry much because it will be mild distress. And on chest X-ray you may see fluid in interlobar fissure, and some amount of pleural effusion will be there, and peripheral streaking will be there. And the treatment here, it's a mild to moderate kind of distress, and you don't have to worry about this condition because it resolves spontaneously within 78 hours, and the supportive treatment is enough for this condition. And this is how chest X-ray of TTNB looks like. There are peripheral streakings and interlobar fissures are seen here. That's it for this video. If you want me to cover any of the topics, please let me know in the comment section, and I will come up with that video soon. And thank you for listening. All the best.